Hello there. Anatomy and Physiology of Digestive Tube or Alimentary System, Part 2. So let's continue where you and I have stopped with the first part of Anatomy and Physiology of Digestive Tube System. And in order to do so, I have to again share the screen with you and to recall some of the slides. And we're to start really from the very last slide that you and I used when we completed our first section, where we talked about six primary functions of the digestive tube, such as ingestion, secretion, propulsion, digestion, absorption, and finally, the elimination of waste. I hope you remember that as we were going through four layers of digestive tube, that we very specifically mentioned two nervous plexuses, the myenteric plexus controlling the third layer, the muscular layer, and that there was a submucosal plexus also present, which was controlling the glands. And this is just a brief interruption where I just wanted to add something that a system of this size and that importance for the rest of the body is certainly not operating on its own. Rather, it has very interesting and very complex mechanism which controls it. Whether we're talking about the neural control or we're talking about hormonal control or area where neural and hormonal simply overlap, that is what essentially controls the system. So if we're to say just a few words about neural control, basically we're talking about some kind of reflex activities. Reflex activities could be induced by stimulating a variety of different receptors that are existing within the digestive tube, whether they're chemoreceptors, whether they're osmoreceptors, whether they're mechanic receptors. Practically food coming into a stomach inevitably is going to stretch the walls of the stomach, and that will be immediately detected, and the presence of content within the stomach is going to be part that we need to further elaborate and to see what exactly came into stomach and how the body is going to cope with this. Sometimes we can even think about reflexes that, technically speaking, are a long form of reflexes, just a sight of food or smell, which doesn't even come from our kitchen, but rather comes from, let's say, the neighbor's kitchen whose window was open, and you get that tiny smell of vanilla. And all of a sudden, we start thinking about food, something containing vanilla. And what is happening? Basically, the brain immediately starts sending signals down to the stomach, preparing it for the stomach to start secreting and preparing for eventual arrival of food into stomach. It doesn't mean that necessarily we are to eat, because we might be at work, we might be somewhere else, we might not even be in a close to any form of food. However, the reaction is going to be there. Uh, Short reflexes, for example, are those ones that are happening in a more local segment of the gut, such as content of the stomach, we know we should call it chyme, starts slowly getting into first part of the small intestine into duodenum. We're talking about 10 to 15 milliliters of chyme per minute. So clearly not a copious amount, but even that minimal amount is going to start triggering the local reflexes, stimulating duodenum for its secretion, and so on and so on. Hormonal activities are also important. As we know, they do not have immediate effect. Nervous system is way better when it comes to speed. However, hormones do have longevity of their reaction. So, for example, a hormone within the stomach secreting is going to stimulate stomach for additional secretion of hydrochloric acid until we establish the proper level of pH value that is optimal for activation of certain enzymes. Or we can have cholecystokinin, another hormone, which stimulates pancreas, which stimulates liver for its production. Obviously, when we need pancreatic juices that are rich in alkaline solute, basically were to offset the acidity coming from a stomach, as well as bile, which is required for digestion of lipids, and also for activation of pancreatic enzymes that simply would not be activated in excessively acidic environment. So that is just a short presentation, more of an idea to kind of keep it in mind as you go through this part of anatomy, just to know that it's not miraculously regulated. It is all controlled, and lots of things are happening at the local level of activation and regulation. Don't forget, that's why we said it is plexus of nerves within the gut, within the digestive tube, that we sometimes, when presenting the nervous system organization, practically put as an independent unit, talking about enteric nervous system. Okay, so I believe this was good enough for us to move on and to go to the next slide, which obviously is going to be fairly short in front of us on the screen, just introducing the concept and introducing the main topics that you and I will be discussing in this second part of our presentation. Obviously, we're taking approach going from proximal to distal direction. In this case, it's not necessarily superior, inferior, but rather we follow the content which is placed into digestive system, oral cavity being the most proximal, and of course then rectum, anal canal, and anal opening being the most distal. That's going to be the direction that we have to take. And in this part, I don't think that we're going to have a chance to go further than anatomy of the stomach. And that is where I'm going to stop recording and post it as a separate video. Oral cavity or mouth is quite complex part of anatomy. We do not have a need to go and explore it in all the details, but we have to have a good grasp of what the oral cavity is. The picture illustrates it with a mouth widely open and both upper and lower lips slightly pulled upwards and downwards. So if we're to formally announce the entrance into oral cavity, it would be space that is marked by superior and inferior lips. And of course, once we pass the level of lips, we're entering pretty much the vestibule of the oral cavity. Vestibule is pretty much a space that is between lips and gums. And if we go further laterally, basically space between our cheeks and gums. Both could be said for vestibule of the superior as well as at the inferior part of the oral cavity, superior and inferior vestibules. Lips are a little bit more firmly secured through labial frenula to upper and lower jaw gums so that they do not become too free and too detached. Basically, they have to be in a fairly close and almost very intimate contact with the rest of the oral cavity. Finally, we can see our teeth, and once we pass teeth of upper and lower jaw, we're going to find ourselves in oral cavity proper. Teeth are going to be presented on their own. We're going to spend a couple of minutes just talking about primary or deciduous and permanent teeth. But for now, we can just confirm. Teeth are inserted into maxillae, which we have two of them, left and right. And therefore, per maxilla, we can have up to 8 permanent teeth. There is just one mandible, so we do not divide it or saying that we have 2 mandibles. Mandible will contain up to 16 permanent teeth. That number, of course, is going to be significantly less should we talk about deciduous teeth. The roof of the oral cavity proper is made of both hard palate and mucous membrane covering muscles that make the soft palate. The hard palate is composed of 2 bones, maxilla with its palatine process, and more posterior to maxilla comes palatine bone, both on the left and right, and they fuse in the midline, so there is no gap between them. That is the hard palate. Posterior to the hard palate comes the muscular segment of the palate covered with mucous membrane. We call it soft palate. And one of the interesting details of the soft palate is the uvula, which we see hanging free from the soft palate in the midline. From the soft palate come two mucous membrane covered arches. One that goes more anteriorly, and that arch gets the name of palatoglossal arch, and the other one is directed more into pharynx, called palatopharyngeal arch. Between two arches, there is a little bit of a depression, kind of pit, and within that pit, we're to find presence of palatine tonsils, left and right. Keep in mind, palatine tonsils are just a larger accumulation of mucosa-associated lymphatic tissue, as what you and I have seen in the mucous membrane layer of the digestive tube. Sides of the oral cavity are practically our cheeks, front wall made by lips, gums, and teeth. We need to mention the floor. Well, floor on this diagram, you could get incorrect conclusion that the floor of the oral cavity is the tongue itself. No, tongue is an independent organ that is part of the oral cavity, which is attached to the muscular floor of the oral cavity. Number of muscles that are running between temporal bone, styloid process, between inner aspect of mandible and the hyoid bone are running and covering basically the space which exists between halves of the mandible. Those muscles like mylohyoid, geniohyoid, stylohyoid are muscles that form the floor of the oral cavity. And finally, should we ask what is happening to the posterior wall? Basically, we have to say it. There is no wall. We have a large opening, a fauces, and through the fauces, we're also able to see part of the pharynx, particularly that's going to be a segment that we know as the oropharynx. Interestingly enough, and you need to know this, soft palate being with its core muscular is pretty much quite mobile part of the oral cavity. As it becomes elevated, when soft palate is elevated, it closes entrance into nasal cavity and therefore ensures that content of oral cavity becomes properly diverted into rest of the digestive tube. With the soft palate relaxed, as illustrated, basically it opens up exit from a nasal cavity and ensures that air freely circulates through the nose, epipharynx, oropharynx, further down into larynx and rest of the respiratory tract. So I believe that this could be perhaps more than enough information about oral cavity per se. And now we can move on to see structures that are associated to oral cavity. One of them certainly would be a group of three major and countless number of minor, only microscopically visible salivary glands. So three major pairs that we're talking about, and their names are parotid gland, submandibular, and sublingual, are those ones that need to be anatomically recognized, and we have to be aware of their position. Interestingly enough, production of saliva, which is a must for maintenance of the oral cavity, and also it is significantly contributing to digestive tract, is something that ranges between 1 to 1.5 liter a day. So it's pretty much quite intense form of secretion. And no surprise then that three fairly large glands are capable of doing the bulk of it. Should we start with the parotid gland, where to find it further posterior to mandibular ramus, the branch of the mandible, practically under the earlobe, because it is covered with a fairly thick fascia covering musculature of the neck. Even palpation of this area would not necessarily reveal presence of parotid gland unless it is enlarged, as it could happen in a case of parotitis, where a virus has preference for affecting parotid glands and causing them to swell, to enlarge. Parotid canal or Stenson's canal crosses from parotid gland and it goes across the cheek and opens inside the oral cavity across from the second molar, second maxillary tooth. So very light pressure on the parotid gland if we have a spatula in a patient's mouth and good source of light actually could identify the opening of parotid canal, seeing exactly where a drop or a couple of drops of saliva are entering the oral cavity. Other two glands appear to be a little bit smaller, and we're to start with the submandibular gland. With a submandibular gland, we're to explore under the mandibular angle and practically just under the mandible, we would feel in the upper lateral aspect of the neck egg-shaped structure, and that is the submandibular gland, hence the name, under the mandible. Submandibular gland, as you're going to see it from the picture we already used, does have a very unusual location for opening of its duct. It is just under the tongue, next to the tongue's frenulum. So these two little dark spots are practically marking the opening of the submandibular duct. The third one is sublingual, and as its name again tells us, it is practically located on the floor of the oral cavity under the tongue. This gland could be also explored with clean hand, going under the tongue and feeling somewhat of a cobblestone appearance of the oral cavity floor, and it will have multiple openings on its own, so no specific opening we need to identify. There are three basic major salivary glands, and as I mentioned it, multiple microscopically visible salivary glands scattered throughout the mucous membrane of the oral cavity. So what is saliva doing for us? What is the benefit? Well, first benefit is it keeps the oral cavity moist. And as we know it, when it's properly moistened, the tongue moves freely, our lips move freely, our cheeks move freely, so we can talk, we can sing, we can whistle, whatever we need to do while maintaining just a proper moisture level within the oral cavity. After the meal, additional secretion of saliva is going to rinse the oral cavity and practically remove any kind of lingering flavor, which we might have kind of lingering for minutes after we completed meal, but not for hours. Saliva also contains salivary amylase, first of the enzymes that we have to add, which starts breaking larger carbohydrate molecules. However, it is not going to break them down to the level of simple sugars. So the process of breaking them down until carbohydrates become absorbable just starts in the oral cavity, nowhere close to be considered complete. And also, like there is a chemical substance which is bactericidal that is controlling growth of bacteria within the oral cavity, preventing oral cavity to become some kind of really like a good host petri dish for development of bacterial colonies. It is not killing bacteria, it is just controlling their ability to reproduce and to increase size of their colonies. It is understood that oral cavity is not completely sterile, as it's not. Therefore, human bite is considered to be quite dangerous thing if it ever happens, as dangerous as being bitten by a wild animal. So we are really trying to maintain the hygiene, and it is done with a little bit of a help of saliva. Finally, saliva as fluid is really essential for part of digestion, which starts within the oral cavity. It is mechanical digestion, whereas food is simply processed by chewing it between our teeth, pulverizing it, making it easier to swallow. And as we chew, basically with the help of tongue and our teeth and our lips and cheeks, basically we're mixing up the food we ingested with saliva and we're converting it into a bolus, which is practically semi-solid, semi-liquid, but something that we have no further difficulties pushing down into pharynx, swallowing, and allowing pharynx and esophagus to carry it all the way down into stomach. I'm not sure if I mentioned it. It's lysozyme, the bactericidal chemical compound, not lysosome, lysozyme that saliva contains. I'm afraid I didn't say it during the presentation, so I just had to add it right now before we move on to the next slide, which will bring us to remaining part of the oral cavity to say just a couple of words about our teeth. So what we're looking at here is a cross-section through a permanent tooth, likely to be one of the molar, more posteriorly located teeth that are shaped for good quality chewing. But we can apply this as pretty much template, regardless whether we're talking about incisors or canine premolars or molars. They're always built in the same form. There's a part of the tooth which is visible. We call it the crown. And a crown is covered with enamel. That is the hardest material a human body can make. Once the enamel becomes damaged, likely again by acidic secretion of bacterial colonies, especially when people do not have proper oral hygiene, basically enamel would start slowly decaying, creating cavities for which one will have to see a dentist. Next part of the tooth, which is practically at the borderline of a gum, it's called the neck, and we can see at the level of neck, amount of dentine gradually is reduced, so we're coming to the base building material that forms the tooth. That's called the dentine. And if we follow dentine, of course, we're now getting into part of the tooth, which is called the root. Some teeth have more than one root, sometimes two, occasionally even three. And the roots of the teeth are inserted into little sockets that are called alveoli of either maxilla or mandible. So they're quite a good fit, matching fit to each other. There's little periodontal ligaments that you can see in between mandible and its alveolus and the root of the tooth. There are ligaments that actually secure the tooth within its socket, holding it firmly, so that forms a joint, which a long time ago we identified as a gomphosis type of joint, something being bolted into another structure. And finally, you realize that the central part of the tooth is actually hollow. Really, it's not hollow, it's filled with a loose connective tissue. However, it is also getting a chance for small caliber arterial and venial to reach and to feed the tooth during the life, as well as peripheral ends of nerve, whether it's maxillary or mandibular nerve, also enter through the root and terminate within the pulp cavity of the tooth. So when the process that we all know, which is called the root canal, is done, and sometimes it has to be done, the dentist needs to open up the tooth wide enough to go with special instrument into root or roots to make sure that they eliminate structures within the pulp cavity and within the root. Once they have cleared the situation, they put special tooth sealant into root or roots, after which they can finally put regular dental filling and close the gap. At that point, tooth is still within the oral cavity, but it is considered to be dead as it doesn't have active blood supply or active innervation. Still way better than to remove it. And the reason for which dead tooth will not be rejected, it is our own tissue, and immune system will not trigger any kind of response right away. As we know, there are two periods in our life that we can name dentition or eruption of our teeth. One affects us when we are basically 6 months old, all the way up to, let's say, 3.5 years old. And during that period of 2.5 years, we're having our first deciduous or primary teeth filling up our maxillae and the mandible. As you can see on the left side of the screen, there are just 20 deciduous or milky teeth. If we start from a midline, first two are incisors, medial and lateral, then comes a little bit more sharper, pointy cuspid or canine tooth, followed by two molars. And these are indications at what period of time they approximately erupt. Usually it is the lower jaw central incisors being most of the time, most typically the first tooth to find its way through otherwise teethless gum of a baby, followed by other teeth, but the total is 20, 10 in the upper jaw, 10 in the lower jaw. Somewhere at the age 6.5, 7, deciduous teeth are gradually replaced, more or less in the same chronological order as they erupted. And in the meantime, of course, our head has significantly grown, our gums have grown, and it makes more space to allow for dentition of our permanent teeth. So the total would be up to 32, and we know that in a mandible, the total number is 16. And per maxilla, we have up to 8 teeth because there are 2 maxillae. There is also a bit of a difference between what deciduous versus permanent teeth are named. So we would have same for central and lateral incisors. We're going to have the same for cuspid or canine, but adults going to have these two teeth being called first and second premolar teeth, followed by 3 molar teeth, of which first one is really usually the largest, and the last one, which is marked on this diagram by 1 and 16 in the upper jaw, 32 and 17 in the lower, is the last one to erupt. We call it the wisdom tooth because it usually happens much later in the life. But the human involvement and further changes that were part of our tradition, eating cooked meal, essentially led to, relatively speaking, shrinking of our gums. And as a result of that, the wisdom teeth do not have as much space as they would require for their proper positioning and proper functioning. That is the reason for which young individuals, usually around beginning to mid of the puberty, are sent to oral surgeon, which needs to remove their wisdom teeth at that time before they grow their big and sometimes quite massive roots. And of course, then their extraction becomes much more difficult. Finally, we have the tongue. And it is, as I said, a separate individual organ within the oral cavity, extremely important for a variety of different roles, not necessarily for the basic survival, such as eating or drinking, but also for proper articulation of sounds, words, and our ability to speak. Basically, the tongue is entirely muscular, whereas left and right half of the tongue are pretty much symmetrical, and there is a big and massive, bit more fibrous septum, which allows attachment of muscles to its left and to its right side. Position of septum also is indicated by this longitudinal groove in the middle of the tongue. Otherwise, the anatomy of the tongue is fairly simple. We have its tip or the apex, we have the body of the tongue, and then we have the root of the tongue, which does look a little bit more intense compared to apex and the body. So what makes the difference? Basically, the surface that you're looking at is the one which you can see if you stick your tongue out. That's called the dorsum of the tongue. On a diagram that we previously used, like this one, the tongue and its apex is elevated. So what you see is very smooth, very thin mucous membrane covered ventral surface of the tongue, which is really so thin that it's nearly transparent. You can see presence of some blood vessels if you do this in front of a mirror. But it is the dorsum, which is for us a little bit more important. Dorsum of the tongue is covered with a number of different smaller, a little bit larger or more large structures that we call papillae. Papillae are projections that are not necessarily to be equated with taste buds. Basically, some papillae would have taste buds, some would not have them. The most dominant form of papillae are those ones that we call filiform papillae, which cover almost entire surface of the apex and the body. That gives our tongue a texture. Filiform papillae do not have any taste buds. However, our tongue is very skilled in moving food back and forth, left and right. Just think about having chewing gum or some kind of hard candy in the mouth. Basically, with the tongue, you can easily manipulate it and very accurately place it exactly where you need it to be. So the texture is important because it provides a little bit of an abrasive surface, offering a bit of resistance to some involuntary and accidental movement of food within the oral cavity. In between filiform papillae, if you take a closer look, you're going to see somewhat larger, a little bit more prominent fungiform papillae. Fungiform because they look like mushrooms, hence the name. Fungiform papillae are quite outnumbered compared to filiform, but fungiform papillae do have the taste buds. And then we come to the third group of papillae that are called valate or circumvallate papillae, and they are arranged in the letter of inverted letter V. They're exactly making the boundary between the body and the root of the tongue. So presence of valate papillae is what we also call and refer to as the terminal sulcus of the tongue, being exact boundary between the root and the body. Valate papillae do have deep trenches that are surrounding them, and within those trenches, basically saliva, which usually contains dilute particles of the food, could stay a little bit longer, and therefore we have this kind of aftertaste that 5, 10, 15 minutes after we consume something, the lingering flavor is still in our mouth. On the side of the tongue, there is a fourth type of papilla. They're called foliate papillae. They're not illustrated here in this diagram. We're going to see them on the next one. And of course, now the root. Why the root has this kind of appearance of some kind of cobblestone? Are these papillae? No, they are not papillae. They are essentially mucosa-associated lymphatic tissue forming what we call the lingual tonsil. We are usually referring to it as one, not looking at left and right, just the lingual tonsil, which practically covers the entire root of the tongue. Two arches that were previously mentioned as going from soft palate in the direction of pharynx and tongue. They are called palatopharyngeal and palatoglossal arch. Labels are on the right side of the screen, and a little bit of indentation between these two columns, basically that pit hosting the palatine tonsil. Let's not be confused with this. This is not part of the tongue. It is part of the larynx, the epiglottic cartilage. So usually when the tongue is pulled out of the oral cavity like this, even in a living person, sometimes you would be able to see not as much, but at least to see this uppermost part of the epiglottis. Let's go to the next diagram, which really confirms filiform, fungiform papillae, dorsum of the tongue, circumvallate papillae, now indication of where the foliate papillae are found, terminal sulcus with circumvallate papillae, arches, palatopharyngeal, palatoglossal arch, and palatine tonsil, lingual tonsil, epiglottis. I also like this black and white diagram because it sometimes offers a little bit more direct clarity. So between the first one and this one, you pick and choose which one would you prefer to keep and to use for your studies. For us, we know the moment we are processing the food or liquid in oral cavity, it would be time for us to push it into remaining parts of the digestive tube, of course, starting with the pharynx. As illustrated on diagrams A and B, while the bolus is still being formed in the oral cavity, notice the position of a soft palate and uvula. However, when we decide to induce the act of swallowing, deglutition, basically contraction of muscles within a soft palate, are putting it in a different position so they completely block epipharynx, and that's why temporarily, while we're swallowing, we're unable to breathe. Swallowing can go into a couple of stages. Oral phase is the one which we still control. Practically, we can determine when to swallow and if we want to swallow. And when we determine it is time that the bolus has been formed and its size and its shape and texture is optimal for deglutition, basically we're going to use the tongue and its muscles to start pushing the bolus into the direction of fauces and to push it into now slightly distended and enlarged oral pharynx. So this part of deglutition is voluntary. The moment we have a food inside the oropharynx, basically voluntary becomes involuntary because the pharyngeal muscles actually start triggering the peristaltic motion. And as a result of that activity, basically the rest of pharynx and the esophagus will quickly and easily allow bolus to descend and to lodge within the stomach. Before we forget, and it is important to indicate that tongue is extremely complicated when it comes to its own innervation. So being muscular, obviously, it needs a nerve that will control and tell its muscles what to do. You can see here part of the muscle looks like running longitudinally front to back. Other muscle runs between mandible and then it shapes itself like a fan into entire length of the tongue. So we practically say that there are intrinsic and extrinsic muscles of the tongue. Intrinsic muscles are those ones that change the shape of the tongue, and extrinsic muscles are those ones capable of moving the tongue. Regardless whether they're intrinsic or extrinsic, they're innervated by cranial nerve number 12, the hypoglossal nerve. That's the last or the lowest position nerve arising from medulla oblongata. So that only addresses mobility of the tongue. Then we have sensation. If you are ever using any kind of prescription or a non-prescription drug, you know, the moment you place that tiny and very light pill on the surface of your tongue, you start feeling its presence. Just as if you are touching very gently any part of your face or your fingertips, basically mechanical receptors will detect that they have been deformed due to weight of object which has been placed onto the surface of the tongue. That is cranial nerve number 5. Trigeminal nerve, through its branch, which is called the lingual branch, is ensuring that we also have good general somatic sensation and feel the presence of different material inside the oral cavity. And then finally, the taste and taste buds. We know that variety of papillae have taste buds, fungiform, circumvallate, and foliate. Filiform papillae do not have. And basically, anterior 2/3 of the tongue, it is cranial nerve number 7, the facial nerve, which innervates the tongue and brings the special sensation of taste. Other than that, facial nerve actually controls muscles of facial expression. So this is one of these hard to believe moments that the nerve could be so versatile to have some fibers for special sense of taste, but also fibers that voluntarily control muscles of facial expression. Posterior third of the tongue, mainly the root, is innervated by cranial nerve number 9, glossopharyngeal nerve, because although we named it as the lingual tonsil, we still have presence of taste buds, and that is what a glossopharyngeal nerve will collect as information about taste. Finally, a root of the tooth as well as oropharynx will have scattered some additional taste buds that are innervated by cranial nerve number 10, the vagus nerve, which the moment we mention it, first thing that comes to mind is, oh, that's the main parasympathetic distributor. Yes, it is, but it also has a tiny role assigned to it to control some of the randomly scattered taste buds and bring additional information about the taste. So when the process of swallowing is in its full swing, basically the bolus is the one which enters the pharynx. Since you and I talked about pharynx quite a bit in the previous sections that are already posted on the YouTube channel, basically I'm just going to ask you to revisit pharynx if you need by going through anatomy of the respiratory tract so that we do not overburden this recording with information which essentially is a repeat of the same story. Epipharynx, oropharynx, laryngopharynx, and then pretty much seamless transition between laryngopharynx into esophagus. Esophagus is certainly the next topic on our agenda. It's a plain muscular tube, an average person about 25 to 30 centimeters long. And as we know, it extends from C6 vertebra, administrative end of the pharynx, through the superior thoracic aperture, through posterior aspect of the mediastinum, staying and sitting pretty much in the midline, and then passing through its opening at the level of T10 vertebra through the diaphragm, through its esophageal hiatus that is surrounded by muscular fibers up the diaphragm. Once it runs through the diaphragm, the very last couple of centimeters of the esophagus could be named abdominal segment of the esophagus, but it is really not that relevant and it doesn't bear any additional significance for you to remember. Esophagus, while being inactive, so outside of swallowing moments, has its walls collapsed. And of course, they are going to expand only to allow content to pass through it. That's bolus or liquid, which we also consume quite regularly throughout the day. Outside of moments when we swallow, the walls of the esophagus collapse, and basically that gives more space for the respiratory system, which essentially is active each and every minute of our life. We breathe more frequently than what we swallow. There are a couple of neighbors to the esophagus that will make things a little bit harder for, let's say, larger volume bolus to descend. One of them is aorta, aortic arch, which crosses anterior to the esophagus, could make a little compression. Also, there would be passage of the left-sided bronchus, which also could impact the wall of the esophagus, and the diaphragm itself, because the muscular opening, esophageal hiatus, also makes a little bit of impact against the walls of esophagus. There are two sphincters that are part of this organ. One is superior esophageal sphincter, which is formed by cricopharyngeal muscle, essentially the muscle which runs like a loop from the cricoid cartilage of larynx around and circularly through wall of inferiormost part of the pharynx. Of course, that kind of sphincter is important to prevent any kind of reversal of content. However, much more relevant is the lower esophageal sphincter of the esophagus. So increased number of circularly arranged fibers form the lower esophageal sphincter, and also the diaphragm with its muscular fibers will increase contraction and will squeeze the esophagus as hard as the diaphragm can do it. It is important because stomach as we know it is already having a very powerful chemical tool that will start truly chemical breakdown of a number of different compounds we ingested. Primarily, it's a hydrochloric acid, which would burn all other tissues but the stomach, which has thick mucus coat to protect it from its own secretion. So lower esophageal sphincter, if it is accidentally bypassed and the gastric regurgitation keeps coming more and more frequently, a heartburn, as people would say, potentially could do quite significant burn damage to the lower esophagus, which may also, if it continues without paying attention to what's going on and leaving it unattended for years, may even trigger some kind of malignant alteration of esophageal mucous membrane cells, which is not really something that we would like to do. My apologies for this long pause, as I had a bit of emergency that I had to attend right away. I will try, if possible, to kind of edit this silent section, and hopefully it will not affect the recording. So we'll see, and if it's not that good, I will re-record it. Hopefully there would be no need for that. So let's go back to screen sharing, and let's continue where you and I stopped, with esophagus being the last item you and I discussed. And we now finally have a couple of minutes to complete this recording and to say a few words about the stomach. If you remember presentation of digestive tube, basically what made stomach being unique is that within its third layer, the muscularis, we're seeing the third layer of muscle, which is running obliquely. It's not surprise because given the fact that the stomach has very copious secretion and that it has to further dilute the bolus and to turn it into chyme, basically the mixing of chyme with its own secretion cannot be done properly without the third layer of stomach, that's the oblique layer. So longitudinal is still there, circular layer of muscle is still there, but we have the third layer, which makes it a little bit different compared to the rest of the tube. We stopped at the lower esophageal sphincter, and it is time now to expand our knowledge and to say a few words about the stomach and its respective anatomy. The first part of the stomach is named the cardia, quite unusual name, because cardia really is given a name due to its proximity to pericardial sac that is sitting just above it, of course, with a diaphragm in between. Then the most elevated part of the stomach, which is frequently referred to as the gas trap, it's fundus. As we know, from time to time, we accumulate significant amount of gas, which needs to be eliminated from a stomach, specifically if you're as adult drinking carbonated beverages, drinking them fast, amount of released carbon dioxide from the beverage could trigger a need to extract the extra gas to burp. Small children, especially those ones who are still babies, whether they're breastfed or bottle fed, sometimes they really rush to go and empty the bottle. While doing it, they also swallow lots of gas, and it accumulates within a fundus. Third part of the stomach is simply named the body. It's the largest part. As you can see, it's shaped like a letter J. And on the body of the stomach, we see two curvatures, one which is smaller and tighter. That's called the lesser curvature. It points to the right side, towards liver, towards gallbladder. And opposite side, it's a greater curvature, which you may remember also as the attachment point of a greater omentum. Lesser omentum, as a matter of fact, is also attached to the lesser curvature, and it connects the stomach with the underside of the liver. Gradually, the body tapers itself off, and as a result of this kind of narrowing of the lumen of the stomach, basically first we observe appearance of pyloric antrum, followed by further narrowing, resulting in appearance of pyloric canal, and then the ultimate part of the stomach, which is called the pylorus, with plenty of pyloric sphincter muscles running in a circular form, because the pylorus means the safekeeper or the guardian. So relaxation of pyloric sphincter will allow partial emptying of the stomach content, which we know it would be about 10 to 15 milliliters of chyme per minute being allowed to enter the duodenum. As part of the anterior wall of the stomach has been removed, you also recognize that its mucosa is thrown into quite visible folds. They are known as the ragae. And of course, this kind of wrinkling or folding of the mucosa is required because they're most obvious when a stomach is empty. However, during, let's say, an average meal, what most of us would consider being a lunch, basically we're ingesting close to 1.5 liters of different content into our stomach, some solids, some liquids. And of course, 1.5 liter is going to significantly expand the stomach, and it will be allowed by stomach's natural ability to distend, as well as its mucous membrane that is going to easily tolerate these kind of cycles of shrinking and distension. Once we pass the pylorus, basically we would be entering into anatomy of a small intestine, starting with its first part that is called the duodenum. And perhaps we can add here, stomach is intraperitoneal organ, while the duodenum pretty much momentarily becomes the retroperitoneal structure. At this point, I'm going to practically show you just this diagram or photograph of a stomach. Now you can see the ragae. This is anatomical specimen. You can see how intense the ragae are. Here is the cardia, here is the fundus, and of course the body, pyloric antrum, pyloric canal, terminating with the pyloric sphincter. At this point, I believe that we can stop here and continue our A&P of digestive tube by starting again with the stomach, with its mucous membrane, with different types of cells, which are interestingly making the mucous membrane. And then we will progress in our studies in the next part of our recording. That's going to be part number 3. Well, I hope that you enjoyed it. Thank you very much for watching this part, and stay tuned. Part 3 is going to be coming also soon. Until then, have a good day and bye-bye.